Good morning, everyone. Can we start, please? I welcome you all to this morning's session, International Best Practices and How Large Federal Economies Have Handled Healthcare, with particular presentation from Canada and Brazil. Before I request the panelists to give their presentations, I'd like to touch upon some of the fundamental issues. You're all aware that public health is a very, very vital determinant of human development, economic growth and prosperity, and well-being of any nation. We have made massive investments in the health sector, particularly for the period between 2004 to 2014. We set up National Rural Health Mission, which was later converted to National Health Mission. We ran National Disease Control Program. And in terms of magnitude, we also ran a project on TB, RNTCP, which possibly the biggest anti-TB project in the world, having treated nearly 20 million people and achieved substantial treatment rate comparable with the best in the world. But still there are problems. Despite all this, we have not been able to get the desired outcomes. There are huge gaps. Even today, 1,700 people die every day because of tuberculosis. Nearly 1,550 to 1,600 die every day because of diarrhea, and diarrhea is not much of a disease in context of what medicine means today. It is just a condition maybe. But we continue to lose so many people every day. Why? Because even today, 42% people do not have access to conduit water in India. There are a whole lot of other determinants connected with public health system. Then there have been spurt in communicable and non-communicable diseases. 1.2 million cancer cases. There have been spurt in cardiovascular disease. 2 million malaria. We had eradicated malaria in 50s and 60s. It's come back with a vengeance. And out of which we have nearly 30%. She brought up yesterday, Ms. Ravi, in Orissa itself, we have 30% of the casualties on malaria. There are, of course, key challenges we have all identified over a period of time. Lack of infrastructure, poor public service delivery, lack of appropriate institutional mechanism, and lack of quality choices for consumers. And above all, the most important, lack of adequate public expenditure. We've been talking since yesterday. We're still among the countries which are the lowest expenditure in health, with 1.3% of our GDP. It's definitely amongst the lowest. China has close to 2%, and some of the developed economies are maybe 6 to 7%. In terms of other infrastructure, well, in hospital beds, we have 0.9 per thousand compared to China's 4.2, and developed economies nearly 7. In doctors, 0.7 per thousand compared to China's 2, and developed countries more than 4. So we are world's largest democracy. We have grown phenomenally in the last decade and a half. And like I said, the physical and mental well-being of the nation and its people has enormous bearing on human resource development, its productivity, and its growth. And it's worth studying comparative systems of many countries, because I always believe it's only the cross-pollination of ideas. It is how we can incorporate the best practices in terms of proven invention across the world, and we include them in our regimens, in our programs, we can overcome some of the shortcomings of a health system. We have a very distinguished panel with us today, and I would begin with my friend from Brazil, Paulo Henrique. Paulo Henrique is a social scientist, Professor Institute of Social Medicine at Rio. He's done master's degree in family health. He holds a Diploma of International Cooperation and Development from University of Ottawa and PhD in Public Health. During his academic career, he has contributed enormously to development of research and published various books and scientific articles on social policies and healthcare. He has been a very important part of Brazilian public healthcare system. May I now request Professor Hendrik to give his presentation.
Good morning. I think we're probably very tired of hearing me. This is the third time I'm here. This is probably should be the first presentation. It would be easier for people to understand our public health system if I could make this presentation before, present it before. So. The idea is to have an overview of how our public health system developed. For a long time, we only had small public services, preventive care, mostly preventive care in the interior land of Brazil and in the big cities also, but mostly in the interior land, and a very small public service for large enterprises workers. Very small amount of the population at that time. And after 1930 to 1966, this grew a lot, but it was still it was a corporative medical care for large enterprises workers, people who lived in urban area. And Brazil was mostly rural at that time, the population of Brazil. Nowadays, it's 85% lives in cities. 85%, only 15% are in the countryside. So, between 1966 and 1988, they unified those different corporative public medical systems that were for each corporation of workers, and they unified them in one single system for most of the population, but not for all the population. And people had to pay for it. They had to pay. They were discounted in the salaries to have access. So who were out of the formal sector didn't have access to the public health system. It was just for a part of the population. This was the time of the dictatorship, mostly between the 60s and the 80s. At the same time, it was beginning to develop a big private system in Brazil. At the first moment, in the beginning of the century, only liberal ambulatory services, some philanthropic hospitals, and that supplied services to the public system. In the 40s, there were created the first patron-sponsored private health insurance system for large companies like mining companies and oil companies. And then after 1966, when the military dictatorship was there, as I said yesterday, there was lots of incentives for the private sector. They created by law a commercial private health insurance sector. Then they gave preference to private contractors for the expansion of public services. Instead of building public service, they were contracting private services. and fiscal subsidies for the private sector. As I said before, every single money we use in private health sector is deducted from our income tax, even companies and persons. So today, 46 million people are covered by this private health insurance system. It used to be more before the economic crisis we are going on now. So we have two parallel systems, like India, a private and a public system, a very strong private system. When SUS, the public health system, was created in 1988, they kept the private system at the side of it, so competing with the public system. And they unified all the different public health systems we had, the federal, state, and municipalities. Some people asked me in the dinner yesterday what a municipality is in Brazil. We have 3 levels of government, and every square kilometer of Brazil is in a municipality. So municipalities, they have a city or a village sometimes, and a rural area around it. So there are different levels of government, 3 different, and every municipality has a parliament, a small parliament. They have their own laws. They are autonomous. They tax the population. They have their own tax system, and they receive transfers from the state, and compulsory transfers, and from the federal level. So they have their own money, and they get money from the other government levels. Well, so SUS was created in 88, and in 90, they passed in Parliament the Organic Act, the Organic Law that organized SUS, and they began to decentralize it to municipalities. It's the only country in the world that organized its healthcare system in the municipalities, in the lower level of government. And this brought lots of problems. Another characteristic of it is that the federal level has to transfer special money for the municipalities and the state levels. It's compulsory. They have to, every month, they have to transfer money. There are special funds for it, federal, state, and municipal funds, so that the money flows by those funds from one fund to the other and can't be spent in anything else, only in health, in the healthcare sector. It's different from India, I think. Huh? You can't spend it in another thing. You can't build a temple. You can put in education, only in the healthcare system. Another characteristic is an important one. There's a strong social participation in the system. People take part of it. There are councils in every level of government, National Council of Health, State Council of Health, and Municipal Council of Health. People are elected for that, and everything that is decided by the government has to be approved in those councils. But you have councils and conference. Councils, they meet every month, and conference every 4 years. And the conference decide the priorities for the next 4 years. It's a very messy meeting, because in the national conference we have like 6,000 people elected from all over the country. So the discussions are very heated, like we had in the afternoon here, but with 5,000 people. So as I said before, the money flows between those health funds, and those councils, they're in the 3 levels of government, but the citizenship representation is only 50%. That's a problem, I think, because the other part are representatives of the governments, of the healthcare providers, some are private, and from the workers in the healthcare system. So it's divided in 4 categories. Well, the major achievements, I would say, is the family health program we have. It's a huge and important program that began in 1994. We have today like 31,000 teams covering 61% of the total population all over the country. There's a huge problem to keep the doctors in the countryside. So it was created a few years ago, a special program to give incentives for doctors to go there. But most of the new doctors that went to the small municipalities in the rural areas are foreigners, Cuban, Argentinian, and Colombian. The Brazilians want to stay in the private system because they get more money for that. There's a strong competition. I think it's the same here between the two systems. This is a huge problem, but there are new incentives, so more and more Brazilian doctors are going to the public system nowadays. And there's even a strong social movement called popular doctors. They are Brazilian doctors that organize and defend the public, our public health system and work in it. In 1996, they created special financial transfers from the federal level to state level and municipalities for the family health system, for what we call medium complexity care, secondary level, and the high complexity care is mostly done in hospitals, so it's the tertiary sector. So there are special transfers for that, and they are controlled by those systems I showed you, those information systems I showed you before, and all the budget is prepared on the basis of the performance they had in the year before. In the beginning of this millennium, Noah's was a norm to start to organize the regionalization of the system. So we have health regions with the 3 levels of services, but it's very difficult to handle because we didn't create healthcare authorities like you have in Canada and most of the countries that have public health systems. So other main successful initiatives is our tobacco control program. It's one of the most successful in the world. Our national medicines program, like other ones like this national medicines program, lowered the cost of acquisition of lots of medicines. We developed a huge generic pharmaceutical industry like you did here in India. This was sponsored by the government. Nowadays, the most important big pharma in Brazil are national companies that produce generics and also some reverse engineering for antiretroviral drugs. We were the first and probably one of the few countries that distribute for free antiretroviral drugs for everyone that needs it in Brazil. And with this policy, we managed to control the costs. So the cost is fairly low. It's, the government can buy the medicines and distribute for everyone. Another important and successful initiative was our psychiatric reform in 2001. We dehospitalized lots of mental patients. We had huge mental institutions with thousands of people. They suffered a lot there, and this is still going on. We are improving it. We have different kinds of institutions to give them to support them, but we mostly close most of those huge hospices and things. Brazil is very well known by those initiatives, I think. This is really, well, I would like to compare with the other 10 big economies in the world, the Brazilian spending. First, we have a very low public spending on healthcare. If we see the total expenditure is fairly high. It's fairly high. Brazil is not very far from Canada or the United Kingdom. 9% of our GNP is spent on health. And it's growing from the year 2000 to 2010. If you compare to India, I think India is better now, I think. Huh? This, compared to the total expenditure compared to GNP. GNP, okay? I use in Portuguese. I put that in Portuguese. PNB, it's GNP. Yeah, GNP. But if we compare with the public spending with the private spending, Brazil is very low. It's better than India, but very low compared to other countries. It's very close to the United States. Even the United States has the biggest private health sector in the world, spends more on the public system than Brazil does. So we are very bad in this situation. For our private health insurance covers around 1/4 of the population, but it takes more money than the public system. It's not very different from India, I think. Huh? Although we spend more money that. Well, and one important factor is that we are having a reduction of federal funding for health. In the beginning of the system, in the 80s, the federal government was responsible for three-quarters of all the public spending. The states less than 20%, and the municipalities only 7%. But with time, the federal level is diminishing, reducing its share, and the states and municipalities have to increase the share. Some municipalities, like the one I live, they spend like almost 40% of all the money in healthcare. Because Petropolis is not a big city, it's only 300,000 people where I live, but we have a strong public network of health facilities and has to spend a lot of money. Petropolis has something like four hospitals, public hospitals in the city, and gets patients from different municipalities around it. It has to spend a lot of money. And when we compare the health spending in the federal budget, health is the red line. Compared with other social policies, it's going down also. Other social policies are growing. I didn't put it, the Social Security, because it's the largest policy. And I compared with other, so healthcare is getting less and less money from the federal government, not the state and municipal levels. So this is a big problem. In the future, I think we'll have lots of problems. Well, I'd like to talk a little bit about the factors that hinder our organization of the system. The municipalization is a big problem because most of them are very small. 70% of them have less than 20,000 people. So it's impossible to have a complete healthcare system for 20. Some municipalities only have 1,000 people, 2,000 people, so you can only have primary health care in them. So there's, as I said before, a very strong political competition between municipalities. They are run by politicians, and politicians compete with each other because they want to go up in the political career, and they have to dispute votes in the other municipalities to become a state deputy or federal deputy. So they don't cooperate at all. Cooperation is an exception. It's not the rule. This is because of our political electoral system, I told you a little bit yesterday. We don't have, as I said before, regional health authorities, so they have to deal with each other, and they have strong problems in deciding what to do because they are competing. They are not. So we developed very specialized vertical networks, like mental health is a specialized system. We have maternal care is a vertical system from the federal level to the municipal level, but there are no regional cooperation. And we don't have, like Dawson said in 1920, the idea of Dawson, the British doctor, was to create a regional organization of the system with the 3 levels. We don't have this very well developed because of the competition between the municipalities. So this is a map with all the municipalities in Brazil with the population range, just to illustrate. Most of them are very small, as I said before. 70% have less than 20,000 people. They're very small. They have a rural life and not an urban life at all. And a very small amount of big municipalities, a strong one with a developed healthcare system and so on. But most of the municipalities, 70%, they represent only 10% of Brazilian population. So this is a big problem to build. Our healthcare regions, this map represents all Brazilian healthcare regions. Some are very big, bigger than European countries, most of European countries, because they are in the Amazon region, very poorly populated, and they are huge, very difficult to transport people. They have sometimes to take, when they have a need for urgent care, you need a plane to take them, because most of the transportation is made by the huge rivers we have there. It takes a long time, so there are lots of planes taking people from one place to the other. I worked in the Amazon for a long time, and I used to do those small planes to fly. It's very careful sometimes. So lots of countries have, as I'm showing there, a regional health authority. Brazil is the only country that dispersed the authority between states and municipalities. This is a real big problem we have. Okay, I'm finishing it. And the system is very unequal. This is an idea of it. With some municipalities have a very good services, but they are concentrated in the most rich areas. And there's also inequalities in per capita transfer values. I'm finishing. The most rich states, they get the bigger share, and the most poor states, they get the worst share. It's not different than what's happening here, as we listened yesterday. São Paulo and Rio de Janeiro, the richest state, they get more money than the others. The Amapá and the Amazonas and the Amazon Basin, they get the lowest transfers. Hospitals and hospital beds are also badly distributed. There's intensive care beds are also very uneven distributed, as we can see there. There's a huge difference between the regions of the different Brazilian regions. We have 5 different regions. The best situation is in the southeastern region and the south, where we have more people and also the income is concentrated. And public expenditure is like that. That's the total on top. And we are having a very strong economic crisis since 2014, and so the public expenditure is lowering, diminishing. This is very. This is not per capita. This is the whole amount of money in Brazilian currency. Those are billions of our currency. So, but it's going down, and it's the same is happening with our private health insurance system. They are losing people, insured clients, and they are getting less money now because of the economic crisis. So there's the downfall in the number of people insured is because of that. And those people, millions of people, are going to the public health system. So it's a burden to the public health system that is also getting less money. So I think those are, the main features. I want to go on more than that because I'm.
Thank you, Hendrik. One quick question for you. We'll take on questions from the floor towards the end. That is, you also mentioned there's a lot of reluctance of your doctors going to countryside, and you said you incentivize them. What kind of incentives? Could you elaborate? Because we have that problem back home.
Yes. Well, the government created financial incentives for them, and for the universities. Universities have to organize resident courses for family health in all over the country, and people that go to those courses, it takes 2 years. They get a good payment, and then they have to stay a few years in the public health system with better payment. So those are the incentives created, the most important. Well, after this period, after 4 years, they go back because they want to get better payment from the private health system. But most of the doctors they work in both systems in Brazil. 80% of the doctors, they work in the two systems. Okay.
One more thing. This is regarding the private sector engagement. You said 100% fiscal incentives when you in the earlier years. How did that model work? Because we are also toying in India with the idea of engaging the private sector in a whole lot of sectors of public health care. What kind of model did you work on? Engaging the private sector.
To engage in the private sector?
Yes.
In the public sector, you say? Well, most of the private sector in the interior land of Brazil, it depends on the public health system. They provide care. We only have like 1 or 2% of people in the private health system are insured by the private health system, but most of the providers are private, so they are hired by the public. So they depend completely on the existence of the public health system. But only a small amount of the money they get is paid according to the prices established by the federal level. So they are able, they can manage to establish that the market price is much higher. The municipalities have to pay them much higher prices than the public recommends, the public system recommends. This is a terrible problem because they are benefiting from the public system. This is a problem, not a.
Thank you, Enrique.
Not a good example.
Thank you very much. May I now request Professor Rama Baru, who's professor at the Center of Social Medicine and Community Health with Jawaharlal Nehru University. She's a very accomplished public health figure. She's a recipient of fellowship from the University of London and Shastri Indo-Canadian Faculty Enrichment Award. May I request you, Ms. Rama Baru, to give your presentation.
Thank you very much. What I really thought I'd do is to reflect a little bit on why comparative health systems are very important. And I think that we can learn a great deal, and this session has been titled as Best Practices. But the caveat I'd like to add to this whole thing is that, when I was listening to the Brazilian presentation and what I've understood about the Chinese or the Canadian health systems, it's extremely important for us to frame best practices within the political context of each of these countries. And we are dealing with countries which are very diverse political histories. And you got a bit of that when Dr. Henrik spoke about, popular doctors movement, for example. It just doesn't come out of the blue as a best practice. It has very deep roots in the social medicine movement, which was actually a political movement in the 40s, 50s, and the 60s. So I think when we look at best practices, we have to look at the socio-political context in which some of these initiatives came to be, and also in Canada as well. And what's very interesting is the two speakers here, both from Canada and Brazil, are two countries where health is on their political agenda. It is something that is seen as a very important election issue, which is not the case in the Indian context. We can have many Gorakhpurs, but somehow the political class doesn't seem to get moved by it at all. You have a lot of blaming that goes on, but there is this human issue which somehow gets completely eclipsed. The other thing which I feel is very, very important when we are looking at fiscal transfers and looking at federalism and fiscal transfers is the way in which health economics tends to sort of separate the preventive and the curative in all our analysis. So, when you're saying, I'm constantly hearing people say, this is the investment in health care. What we are really talking about is medical care. And I think even in the case of both Brazil and in the case of Canada, when you talk about the national public health insurance programs, you're really talking about medical insurance programs. You're talking about curative care. And I think this is very important for us to understand, because I was just thinking that what are the limits to federalism and what are the limits to transfers to, saying state is ultimately is a responsibility of the states. The reason is there is a very interesting article which I was reading on Canada, where they said that, of course they have a very robust public health insurance scheme which really covers curative services and in some provinces also, preventive services. But what happens when there's an epidemic? So what kind of public health fiscal planning do you need in place? And I think these are important questions, because if you say states and local governments can plan everything, unfortunately the epidemiology of diseases does not really, does not really allow us to look at these in compartmentalized forms, because I think when you look at any epidemic or any major, tackling any major communicable or even non-communicable diseases, you need to have some level of planning from the central level. But having said that, you also have discrete programs to address different diseases. And I think I'm not completely against vertical programming, but the way fiscal transfers happen for vertical programming also signals political priorities, in the sense that there's some programs that get higher political visibility than other programs. So, the WHO, in fact, and this is just not in India, it's globally as well. So the WHO, in fact, clubbed together several diseases which are not killer diseases, like filariasis and a whole range of other things, and clubbed them together and called them neglected diseases. Because they realized that even at the global level, they don't get the visibility that they should, and they don't certainly get the funding that they should. So one of the problems of this kind of separating preventive and curative services is then we don't really have a comprehensive view to how to plan fiscally for public health. And it's interesting that the debates in Canada are, I think, useful for us to sort of maybe think about and deliberate. I think what happened with the Sars epidemic in Canada really brought home this point. So there was a lot of very interesting debate on public health fiscal transfers. And what they were basically saying is that should we really go for a vertical plan approach to disease control, where you look at, say, not in the Canadian case, but in the Indian case, malaria, filaria, HIV independently. And there was a very interesting suggestion, and I would like to hear from our Canadian professor here. They talked about block development grants, and which I found quite interesting, because then, this thing of sort of compartmentalizing it disease-wise, is that the most efficient way to use money? And I think that was a very, very interesting aspect which I felt in a sense brings both the curative and the preventive together, because very often we think preventive is vaccine and technology, and that's the way we are moving more and more. So do we have a dengue vaccine? Do we have a malaria vaccine, etc.? Whereas if you look at it as both the curative and preventive are absolutely essential for any public health program, then you would be able to address the systemic weaknesses. And is that, I'm asking the economists, I'm not an economist, but I would certainly, I think it's an interesting question for economists to answer, is that a more efficient way to use resources? Because vector-borne disease control programs share certain common needs. And so whether you're talking about vector control, or you're talking about curative interventions, or you're talking about even technologies, the point is the health system and the health service system inputs become very critical. So what we are really having is, I feel, and a lot of inefficiencies created by actually splitting the communicable disease control programs and the non-communicable disease programs. And we know from epidemiology today that there are continuums. And I see Dr. Ambuj Roy here, and he would tell you that cardiovascular diseases are not to be seen independently of a history and a life course of undernutrition and communicable diseases. So I think we have that set, there's one set of those challenges, but there is also comorbidities as a challenge. You are talking about tuberculosis, Dr. Dalbir Singh. We now have evidence to show that patients who suffer from tuberculosis are also suffering from diabetes and other kinds of non-communicable diseases. So what I'm basically saying is it really wise for us, if we want to move, I'm sorry I wasn't there yesterday, but towards a comprehensive understanding of primary health care, can we really discrete, even from the point of view of any analysis and design of fiscal transfers and the role of the federal and the state and the local into these kinds of discrete programs? Can we learn something from the Canadian experience? I don't know how successful it was, but I think it sort of set me thinking about, do we really need to move away from a vertical model of disease control? And what does that mean? Because the moment you give a fiscal signal, you also have to go in for administrative reforms. And I don't think you can sort of say that, okay, we've now changed the whole fiscal arrangement, but our systems, what kind of readiness is required? What kind of, home restructuring is required to really address some of these larger fiscal shifts and changes that would be in place, but also how would the administrative structure respond to it? What kind of reforms would you need in the administrative structure itself? And in that, already we have certain privileges that have sort of seeped into this system. So the contestation from the more visible, the more powerful of programs, we've had a long history, and I don't want to go into it. For example, the privileging of malaria over other non-communicable diseases during the period of the World Bank reforms is an example, or HIV/AIDS, and how did that translate into the working of the health system itself? And I think RCH, or the reproductive and child health, is a very, very important issue. But I think it was very interesting, the second issue that the Brazilian experience throws up is the way in which the private sector and its role. And when you spoke about the private and the public being separate, Dr. Paulo, I don't think that's the case in the Indian context at all, because you do have private interests in the public sector, and it's a long history. It's not a recent history, and it has just become much more entangled. And therefore, when you talk about incentivizing the private sector, it is not just the government wanting to incentivize, it is rather the reverse. The private sector is a very, very powerful lobby, and it reshapes the way in which you do, you plan your fiscal systems and your fiscal policies. So I think unfortunately, the world is not flat. And I think this is particularly true in the health service system. I think over time, maybe we need to bring in questions of power and the contestations and the conflicts that it produces, because I was just talking to Mr. Kumar before the meeting, and I said, you want to restructure medical education in this country. What is the view of your IMA? And he said they are a trade union. I don't think we should talk to them because they will be very confrontationist. But the point is, the IMA, the MCI, and many of the business lobbies, the CII, FICCI, they've been very, very active lobbies in pushing and shaping policy. And actually the health ministry in itself has very little power because they have access straight to the finance ministry. And I think we need to understand these dynamics when we are talking about fiscal transfers, because it's not, I mean, we shouldn't give the impression, I'm not talking about Brazil, but I'm talking about India, that somehow the government is in full command and it is going to push in what it thinks is good fiscal reform. I think what we are really going to have is a negotiated, maybe very often a compromised outcome in the way in which fiscal policies are made. I think I'll stop here, and hopefully there'll be more discussion. Thank you.
Thank you, Professor Baru. Just have a small question for you. You also mentioned that in the last few decades, our focus has shifted to curative technological advancement rather than, actually we totally diluted, I shouldn't say lost focus on the preventive health care. And, you know, vector control, sanitation, hygiene, you know, some of this, I think maybe 30 years ago, there was a lot of focus on that. And I'll give you a small example. I come from Army background. Army serves in some of the worst areas of the country. We have a doctor from the Army here, my colleague, in Assam, Arunachal, Nagaland, and all these places. And we have the lowest incidence of malaria. It's largely because of preventive health care. There are hardly any cases of malaria in even the armed forces. And why don't we shift our focus back to preventive health care? Could you elaborate a little more on preventive health care?
That's why I said I don't see preventive and curative as separate, because public health basically tells us that you need good curative interventions also to, you know, reduce infection. And so what I'm saying is that you cannot see spraying of DDT as preventive if you don't have a, you know, a good health system which does surveillance, which actually treats cases, which is able to reduce the pool of infection. So this, in my view, there is this false dichotomy of preventive and curative. To me, they are extremely important, interrelated, and they cannot be discreted. And people like Abhay and others are here, and I'm sure we can discuss much more of it. But generally, in the area of health economics, we tend to discrete it, and that is one of my worries, that, you know, then when there is an epidemic, you say, oh my God, where is the curative services? And you have a weak public health system which is not able to respond. So I think we need to think about many of these interventions and fiscal transfers not as discretes, but actually trying to see how you build systems which include both the preventive and curative in a much more comprehensive and an integrated manner.
Thank you, Professor Baru. Now I would request my third panelist, Donald Philippon, to give his presentation. And Donald Philippon is a special advisor to the Provost and Professor of Strategic Management Health Policy at the University of Alberta. From 1997 to 2004, he was Executive Director of Health Sciences, responsible for interpersonal initiatives amongst the 6 health science faculties. Dr. Philippon also serves as Special Advisor to Saskatchewan Academic Health Sciences Network. He has also been Assistant Deputy Minister in Saskatchewan in 1987, and from 87 to 94, Professor Philippon served as Assistant Associate and then Deputy Minister of Alberta Health. He also chaired several interprovincial committees, including the Conference of Deputy Ministers of Health. May I request you, Donald Philippon, to give your presentation.
Thank you. I appreciate being here, and I know most of you were here yesterday, so I'm going to repeat a little bit because I want to go back on a few points that have been raised since, and I realize now there's another Canadian in the audience, so I got to be careful what I say in terms of accurate. But anyways, I'll get to this presentation here. I can do that. So I want to come back to a couple points here that I think are so important when we talk about comparative health systems, and I'll certainly try to address some of the points that Professor Baru has raised here before. But certainly, I mean, Canada is a very large country geographically, but a very small population. It's very dispersed, as you can see. So if you look at this map, you'll see Quebec has about 8 million people, Ontario 14 million, and Alberta has about 4.5 million, and BC has 5. All the other ones have 1 million or less, and the territories have less than 50,000 each. So we're talking about a real dispersed population. Comparing now with the Brazilian, presentation, I mean, Canada has had a universal health system for now the last 50 years. The previous speaker is quite right. I mean, it's really focused largely on hospital and medical care, and I wouldn't say it's really comprehensive, and I'll come back to that. But certainly 50 years of hospital services and medical services being available on a universal basis to everybody without any charge. And in fact, the Canada Health Act, which came in 1984, specifically puts penalties in if any province tries to invoke a user charge for seeing a doctor or for being in a hospital. That is actually prohibited in Canada. So that's a very important point. The second point I think that's important to make relative to the discussion late yesterday afternoon is the importance of fiscal federalism to make this work. The reality in Canada is that, the first universal hospital plan, and in fact the first universal medical plan came in one province, Saskatchewan, which has 1 million people, and at that time I had less than 1 million people. It was a very poor province, and in fact I'm originally from there. That's probably why my interest in healthcare was so high. But certainly they would not have been able to maintain that program had the federal government not stepped in. And we would not have a universal system across Canada without the intervention of the federal government. They came about in the late 50s and 60s and basically made financial arrangements with the provinces that really made it almost impossible for them not to with the 50-50% cost sharing. So the point I want to make here, and I know yesterday there seemed to be a lot of debate in the room about how much force should the federal government put in place. If you didn't have the federal government in Canada doing that, it would not have happened. I have no doubt about that whatsoever. So you have to figure out in a federal situation is what kind of leverage is appropriate for the federal government to exert while recognizing the competence at the provincial and territorial level. Because it's true that they best know the health needs of the regions. But one without the other does not make the system work. You need to have both things in place. And I think that's the balance we're trying to find in Canada. Moving on then, so just repeating this, I mean, obviously the province have a constant responsibility for the delivery of health care. Federal government sets national priorities and transfers funds to the provinces. And I said before, we don't have one system, we technically have 14, but they're all interlocked because of these criteria. These criteria are very important. They came in the Canada Health Act, and basically the federal government can hold the province accountable for them. Now, coming back to the previous presentation, it's true that once the money actually leaves the federal government and goes to provinces, the strings are not attached in terms of where they actually spend it in health care. It was intended initially for hospital medical care, but the province can use it for other health services. Now, in reality, the Canada Health Act only has the ability to penalize provinces, however, for services they do not provide in the area of hospital and medical care. So even though some of them use the money for elsewhere, the penalties can only apply to in the other areas. I talked yesterday a bit about the functioning of the system. I just wanted to come back to a point on this slide that at the federal level, they provide overall direction. The Public Health Agency of Canada was a direct result of the Sars epidemic in Canada. It was created in the mid-2000s after the Sars outbreak in Canada, and is there as a national agency to kind of coordinate what's going on in the public health domain across the country. There's no question that most of the public health programs are still delivered at the provincial level, but with a lot of coordination at the public health agency level. And there is still debate about how much leverage they should have, how much push they should have to be able to make things happen. But it's a very important part of the Canadian system at this point in time. So at the provincial level, there's a couple points here, is that basically the action on healthcare is at the provincial level in terms of setting direction, of funding, and paying to physicians. Remember that the vast majority of physicians in Canada are private businessmen. They bill on a fee-for-service basis, but they bill to one payer only. That's the government payer. That's the single-payer system. But we do not have salaried physicians. There are some, but they're certainly the minority of that. There's an increasing trend towards having more per capitated systems, but usually they're kind of contracts with a group of physicians and so forth. But we have a lot of private elements within the system, within a single-payer system. A lot of contracted for services and for the diagnostic area, for example, lab and x-ray, a lot of contracted for long-term care beds and private providers and so forth. Health authorities, though, which exist in all the provinces, are there to provide, kind of oversee the health service and try to bring about a better continuum of care and to better integrate service across the different lines. And that's where we try to break down this preoccupation with hospital and medical care and try to move into prevention and health promotion and other things. Now, in reality, after 10 years of regionalization in Canada, I'm sorry to say that I don't think we've made the shift nearly as much as we should have. It's still predominantly the money going into the curative sector. That is correct. There's a lot of attempt, however, to move it, but we haven't been all that successful as much as we want. I talked about this yesterday, about the source of funding. I don't think I have to go into that again, except on the transfers. Yes, the money comes in two ways. Equalization is not tied to anything in terms of what you have to spend it on. It's there basically to adjust the revenue base of the provinces. But the Canada Health transfer is, in fact, linked to what you spend in health care. Although in that respect, you can spend the money in different areas of health care. It doesn't have to be specifically. So the idea that we have talked about block funding for different aspects of diseases, but that really hasn't not come to pass. Okay. But as I said yesterday, 40 to 50% of every provincial government's budget is health care. It's a very big financial expenditure, and certainly it's very high on the political agenda. It's very much a political issue in Canada. To keep the system coordinated, as I said yesterday, we have annual meetings of the first ministers, the premiers, and the prime minister, and we have a real committee structure under what we call a Conference of Deputy Minister of Health. And the reference that I chaired, I don't chair that anymore. You only chair that when you're actually a deputy minister. I did that for a couple of years. And we have a whole number of other organizations that have been created since the late 80s to try and better coordinate things across the provinces. And they provide a lot of the influence on the system to move it in certain directions. This just gives you a breakdown, and I should say on the regional health authorities, there is definitely a move afoot in the country to consolidate those authorities. Certainly in the province I'm from, when I was deputy minister, we actually moved from about, I think, over 300 hospital boards down to 17 health authorities. That later went down to 9, and now it's down to 1 authority for the whole province. Now remember, the province only has 4.5 million people, okay? So there is a lot of consolidation taking place, but it's still, the health authority is a distinct operational arm. It's not directly run by government. There's a board in place that oversees the authorities, and it's their job to develop an effective health plan for the region that they serve. Now, I want to spend a few minutes on where we in Canada are focusing our attention these days, and that's on system performance. And we don't think, and to a certain extent, the success of the Canadian system in some ways is our drawback at this point in time. Because people have come to accept it so much as, the Canadian system is so great. In reality, it's not so great. I've written so many papers in Canada when I was in the government to show how good we are. It's very easy to show how good you are. You live next to the United States. You all put up their numbers and you can show how good you are. But you start comparing to other countries that have publicly funded universal systems, you don't look so good anymore. Okay? The second thing about Canada is that people really like the system. But the preoccupation with hospital and doctors at the expense of preventive and so forth does create problems in the system. We have to break out of that. So trying to convince the Canadian population you have to change the system, and I think it's pretty good, is somewhat of a challenge. But this chart put out by the Commonwealth Fund, basically, and this looks at 11 countries, they're all developed countries. And you can see that on that, Canada doesn't look that well, because we actually, on that chart, which is 2014, ranked 10 out of 11. 11 being the worst, which is the United States. 1 being the UK, and so forth. Overall ranks the top line. And breaks it down by different categories. So we feel there's a lot of areas we can do in terms of making care more effective, better quality care, better coordinated care. So compared to the US, we look good, but not compared to others. And we're very mindful of that and doing a number of things. In fact, I guess you don't have my most recent resume. We've got a new fellowship program with health system leaders that I'm in charge of the country, trying to focus on health system performance and how we're going to improve that. On that same study, which is even more, troubling, is that Canada seems to be slipping. Although I must say in 2017 we went up a notch, we slipped ahead of France. They are now 10 and we are 9, but still it's not something to be extremely proud of. So I want to comment on one other, because that other measure that I talked about is largely a lot of survey data, people's perception data. There's a lot of indicators built into it. But there's other ways to look at health systems, and this is one you might be interested in. Some of you may have heard about it. It's a new index, Health Access and Quality Index, published in Lancet in July 2017. It actually builds on the work that McKee and Nolte have done at London School of Hygiene and Tropical Medicine, which is the global burden of disease, tracks 32 disease categories, and from that creates an index. It's quite complex. The number of collaborators on it are immense around the world. And this morning, I have the last point says India, which wasn't on my slide before. I wasn't ever talking about India, but since I'm here, I thought I'd put India on there. And I had to look through to see who's all involved. And I do have some names of people who have been involved in development of this index. But the important point about this slide for us, on this one, Canada does look a little bit better. We're up at 88, the highest, of course, being Switzerland and Sweden and so forth. And this looks at the actual incidence of various kinds of diseases and so forth. So in that respect, we do better in terms of people's perception of how long they have to wait for services, how good the access is. There's issues there. But you'll be interested, of course, on how this study is together. And because I put India on, I felt obligated to say something about how this is structured. So this ranks 195 countries, and it divides them into 4 panels, depending on what they call the social demographic index, which is basically an index created from wealth and a level of economic development in a country. And in those 4 panels, Canada's in the panel A and India's in panel C. The range in panel C is from 75 to 36, with Syria at 75 and Angola at 41, India's at 45. And when I tried to figure out why is India so low, it's some of the things, and actually gives you nice little charts. If you pull out that article, you'll see them, and you get a chart like that. The greener it is, the better you are. The redder you get, that shows the kind of areas you have. But the areas that India ranks low on are tuberculosis. We talked about a lot about here. It's at a score of 26. Neonatal disorders at 14, and this out of 100, remember. Rheumatic heart disease, 25. Hypertensive heart disease, 33, and chronic kidney disease at 20. So some of these scores are bringing down the overall average. And I'm certainly no expert in this particular analysis, but you want to look at it to see what it might say to you. Is the need to broaden our base of services beyond hospitals and medical care, to shift from hospitals and to community care, to look at more preventive care, to more upstream kinds of issues, dealing with the social determinants of health. There's a major issue with prescription drugs in Canada. It's one area that we did not include in the initial hospital and medical care legislation. So drugs are only covered if you're actually in the hospital as an inpatient. Once you leave, you don't have them. And there's tremendous inequities across the country. It's interesting, though, that it provides us with a really good snapshot of how the private sector works. Because what's happened, to fill that void, we have all these private sector plans now in place. And for most people in Canada, they think it's very good because their employee benefit gives it to them and you will get a prescription for nothing. But when you look at the overall cost to the country, how much they're paying for those drugs, the poor coordination, monitoring of drug utilization, compared to other countries. All these other countries that have universal publicly funded systems, like Sweden, like the UK, Australia, all have national pharmacare programs. And that's a big push in Canada right now. But we're going to have to upset a lot of the insurance industry to make that happen. Home care don't get the attention they deserve. We have very serious gaps with the health status of our indigenous population. And of course, they live in many of them live in these very remote areas. So that's a major issue. And that will never be addressed by just thinking about how we're going to deal with the hospital and medical component of that. I mean, this is really the social determinants of health have to come into play, and that's where a lot of other government agencies are probably more important. You've probably seen some of the analysis will tell you that a health status of a population, if you really look at it, only about 25% can you explain in terms of the contribution of the healthcare system. More than 60% comes from social determinants of health. And of course, the final thing, and when I showed you that map before, you'll notice we have about 100,000 people living in very remote areas. We pay a high price for transporting those people, high cost of transportation to get them to medical centers and so forth. So those are some of our challenges, and maybe I'll stop there, and if there's any questions, you're pleased to try and answer them.
Thank you, Don. We are running far behind schedule. We have exactly 15 minutes to wind up because I've been permitted to take it till 11:05 because we began late in the morning. May I now request Mr. Kumar, who is a very senior bureaucrat, as advisor health with Niti Aayog, to give his presentation. May I request you, Lokji, to keep within 8 to 9 minutes so that we have at least 5 to 7 minutes of a couple of questions from the floor.
Sure. Thank you. So, since time is limited, I thought what I would like to stress mostly on is how we do fiscal transfers on health in India, and what we are thinking of in terms, it's still in the ideation stage, so would look forward to comments also. So one of the things to note is that the fiscal capacity of the central government is greater than the constitutional responsibility assigned to them, and the fiscal responsibility of the states or provinces is lower than the constitutional assignment of responsibilities as we have done it. So therefore, there is always a case of fiscal transfers, and the government uses its, the central government uses its fiscal capacity to influence policies on the state, on health and education, on other subjects which are really assigned to the states. However, this leverage is limited. For one, at least on the health side, the state governments together spend thrice of what the central government does. Number one. Number two, if you look at in an overall scheme of things, out of the total budget size, only 10% is in the form of centrally sponsored schemes, which are essentially those schemes where the central government transfers resources to the states to address that, and health happens to be one of them. If you look at health itself, it is less than 1% of the overall budget of the center. With this amount of limited leverage, two things are obvious. The first thing is that if the central government really wants to play its responsibility, A, it has to increase its overall spending on health. And secondly, it also has to be seen whether the states will come up with their matching share, because in our scheme of things, for every rupee which the government of India does, the states are expected to match with their spending. So there are states with, so when there are states with different revenue capacities, this becomes an important issue. Now, with respect to transfers, now how best do we do the transfers? Now there are two often what I would say divergent principles. One issue is that of equity, where you would like to assure every citizen a common minimum level of services. And then there is another imperative, which is the efficiency issue, where you would like that any money which the center gives to the states is utilized in the most efficient manner which is possible. And many times, because of capacity constraints, because of governance issues, because of resource issues, many of those states who are really in terms of health outcomes, really much below the national average, we find it very difficult. So now at the present moment, the way we are giving our resources to the states, 90% is on account of backwardness and 10% is account of performance or incentive based. Now, if you look at how the spending actually happens, even those states where, though theoretically allocations because of 90% being weighted on the backwardness, in actual spending terms, it turns out, and I think Govind Rao probably presented his paper yesterday, it actually turns out over a period of last 10 years that it is those states with better health outcomes who are able to better spend, and therefore at the end of the year they tend to end up with higher resources than what was intended of them. So even when we look at assigning the resources on the basis of backwardness, even then it turns out eventually, as it in practice, that we are not able to handle the governance constraints of the states, because unless that is handled, whatever amount of allocation in terms of budgetary terms merely remain allocations, they don't translate into outcomes. So one of the things which Niti Aayog is trying to do at this point in time is to try and develop an outcomes-based index which measures the performance of the health system of states in terms of outcomes. We have done that, and the idea is to link incremental outcomes. So if you look at a large number of states, historically they are so far ahead of the other states that if you do a transfer on absolute outcomes, maybe it may not be a very fair supposition. So now what we are trying to do is to look at how an incremental performance of the state health outcomes on a given day, in a given year, can then be used as a basis to earmark a higher proportion of funds to the states. So that would imply that there will be a part, and this could be debated where it could be 70-30, it could be 80-20, it could be 60-40, whatever. We have done, for paucity of time, I'm not making the presentation, we have developed 4 different models of this fiscal-based transfer, and we have also worked out on the basis of actual performance between 2014-15 and 2015-16 as to which states will gain and which states will lose on this count. And we hope that we would try to give this in terms of discussion. You know, the current system of allocation is based on 1,500 budget lines multiplied by 29 states plus 7 union territories, and this, to my mind, is only an Indian mind can recognize this complexity. And what we have been arguing with the health ministry is that I think we need to reduce the number of these budget lines, and while at the same time recognizing the point what Rama was making, that it should not be prioritizing one disease over the other disease. So you need to give some blocks, and maybe 6 blocks, 7 blocks, 10 blocks, 15 blocks, that you could kind of argue, and then give the autonomy to the states to decide as to where exactly they want to use based on what the Canadian model is. I think this prescriptive approach, particularly considering the diversity of Indian states, where there are states where 80% of the people prefer to go to private sector, and there are states on the opposite side where 80% of the people are dependent on the publicly run health systems. So I think there is a need to recognize this diversity and give more autonomy to the states to decide where exactly and how exactly do they want to run this. And so, so the point I wanted to make was that my sense is that we should be a little bit more trusting of the states, give the provinces a little bit of a more autonomy, allow them different experiments depending on what they feel would work in their states. And if there is an argument about capacity, the answer then is to build their capacities rather than piling up more and more capacities at the Delhi level and try to influence the policies from there. Thank you so much.
Thank you, Mr. Kumar. We just about have 5 minutes for the question from the floor. Please. Yes.
Back. This really is the final grand finale of the 1.5-day conference that we've all gathered here for. This session is on intergovernmental approach to better health in India. And as has been the discussion over the last day and a half, we know that health cannot be compartmentalized and focused narrowly within the health ministry alone. There is a need to take the discussion over and beyond the vertical lines that Rama spoke about in the earlier session. So I'm very happy to introduce to you our panelists, speakers for this last session. We have with us Mr. Rakesh Srivastava. He's a Secretary, Ministry of Women and Child Development, Government of India. We have Sri R. Rajagopal, Additional Secretary with the Interstate Council Secretariat.
Good morning.
And Shri Satyavrat Sahu, who's a Joint Secretary in the Ministry of Drinking Water and Sanitation. Let me start out, gentlemen, by asking you to first give us a sense of what is the involvement of your specific ministries, just to lay the ground as far as your ministry's involvement with health policy and implementation of some of these public programs are concerned. So if I may request Mr. Srivastava, if we can start with you, sir.
Thank you, Director Saab and friends. In the Ministry of Women and Child Development, you may be aware that we are giving 6 services to the client group. The client group basically comprising the pregnant and lactating women, the children from 6 months to 6 years, and then the adolescent girls from 11 to 18. These are our 3 client groups, and we give them a package of 6 services, basically early child care and education, supplementary nutrition, then health monitoring, inoculation, and all these things. We have, through the Anganwadis, you may be aware that there are 14 lakh Anganwadis in the country, 1.4 million Anganwadis, and the total number of beneficiaries is 10 crores, that is 100 million every day. So that is the number of people whom we cater to on a daily basis. This program is the largest program in the world, and it is being monitored by us. What we are doing is that with the help of our supplementary nutrition program, we try to cover the nutrition deficit. Nutrition deficit meaning what is the recommended dietary intake and what is the actual dietary intake in terms of carbohydrates, in terms of protein, in terms of fat, etc. There is a gap. So we try to cover that gap. It is not meant to replace the normal nutrition. It is meant to act as a supplement. And we do this through the take-home rations and through the hot cooked meal. This is in this we are implementing the National Food Security Act of 2013, and in addition to this we are in 2017 February we have issued what is known as the National Supplementary Food Security Act rules, under which all these things are being implemented, and we try to see that the nutrition deficit is completed. In spite of our best efforts, what we have found is that the levels of stunting or wasting or malnutrition in the country, although it has gone down, certainly it has gone down as compared to NFHS 3. The NFHS 4 figures show that there is a downward trend, a perceptible downward trend, but it is far from satisfactory. And we are now currently, this is the latest what we are doing in the ministry, is that we have identified for ourselves targets that we want to keep per annum for reduction of the stunting, malnutrition and wasting. It is ranging from 2% to 3% per annum. That is the maximum that you can reduce in a calendar year or in a financial year with the best of efforts. That is first thing that we are doing, and we have given to the Prime Minister's office and to the larger government an ambitious target of reducing this malnutrition and having a malnutrition-free India by 2022, when India celebrates the 75 years of its independence. How do we do that? We do that through 2 means. Firstly, by convergence. What Shamika was mentioning, now it is no longer possible to work in silos. You are in health ministry and he is in drinking water and sanitation, and I am in WCD, and therefore we should just work in our particular fields. That is now no longer feasible. So because if the sanitation is not assured and if there are the deworming and all is not done, then no matter how good your nutrition is, it will come to a naught and the malnutrition will still be there. Therefore, all of us, we have to work. There has to be drinking water, there has to be toilet, all these things. And then with the help of the Ministry of Health, we take up things like our Anganwadi worker along with the ASHA and along with the ANM. They are carrying out these surveys, and we are in the process of having real-time monitoring of the nutrition that is being given to the children. And we hope that by this method, we will be able to have a malnutrition-free India by 2022. The ministry is working along with the three ministries. We are working with the Prime Minister's office and also with the Niti Aayog. So this, in a very short, in a nutshell, I have tried to just explain what my ministry intends to do, because combating malnutrition is one of the foremost jobs of my ministry, and we are working in conjunction with these 2 or 3 ministries and these government bodies. Thank you.
Thank you, Mr. Srivastava. May I now request Shri Satyabrat Sahu to talk about his ministry? Thank you.
Thank you. Just may I add, both Rakeshji and you, if you wanted to add just a couple of minutes on what's happening in your state also, as an IAS officer coming at both places, I think that would also be challenges and opportunities kind of a thing.
Thank you, sir. So, I am from the Ministry of Drinking Water and Sanitation, Joint Secretary looking after the rural water supply sector. There is another Joint Secretary who looks after the sanitation sector. We call it Swachh Bharat Mission Gramin. This is the program. So, there are 2 programs. The first program I will tell about the National Rural Drinking Water Program, which I handle in the ministry. The goal of this program is to provide safe and potable drinking water to all the rural households of the country by 2022. The original plan was 2022 because the program started in 2009-10. But now, seeing the progress, we are thinking it will be stretched beyond 2022. But the first focus under this program is to provide potable water. Potable water is important because out of 17 lakh rural habitations, I am dealing with only rural habitations, and rural habitations are 17 lakhs in number. In India, we have 6 lakh odd villages, but 17 lakh habitations. That means every village has 2 to 3 habitations. Habitation is a part of a village, homogeneous settlement. So say out of 17 lakh habitations, the potable water problem is only in 70,000 habitations. These 70,000 habitations are facing problem of arsenic, which is around 18,000, mostly in West Bengal, Assam, Bihar, Uttar Pradesh. These are the states, along the Ganga river. Then we have problem of fluoride. Fluoride is maximum in Telangana, in Andhra Pradesh, in parts of West Bengal, Bihar, and mostly in Rajasthan. So there are few pockets of the country where this is the most dangerous issue from health point of view. Since this is a meeting on providing intergovernmental approach to provide better health in the country, so this fluoride and arsenic is the big challenge and big issue for us. And we have decided to completely eliminate it through some permanent processes by 2021. So while we will stretch for pipe water supply schemes, pipe water supply is the supply through the pipelines. Presently it is at around 55%. So we will reach around 75% by 2022. If more funds will be made available to the ministry, we may do better. But definitely after a couple of years of 2020, maybe 2025, we will finish this 100% pipe water supply to all households. So remaining people, 55% are getting pipe water supply, remaining around 40% people are getting water through hand pumps. Hand pumps or groundwater based tube wells. So the main objective under NRDWP is to provide water to the rural households. We have around 18 crores rural households, 90 crores rural population, 17 lakh habitations. So far the financial and physical thing is concerned, we have fixed a norm so far water is concerned. In rural areas, unlike urban areas, we will provide as per the Niti Aayog norm, 40 liters minimum water, 40 liters of water per capita per day. This is the minimum requirement in the rural areas. In urban area, it is around 135 liters. In some states like Gujarat, they have touched around 100 liters. In most of the southern states also they have touched southern 100 liters, but in many parts of the country, 40 liters, 78% people, 78% of the habitations in the country, roughly let's say 80% of the people are getting 40 liters. Another 15% are getting between 20 to 40 liters, partially covered. And 4 to 5% people are facing problem of quality. So if you divide 100% population into 3 categories, fully covered around 80%, around 15-16% is partially covered who are getting less than 40 liters, and 4 to 5% are quality affected. So our aim is to provide everybody again 40 liters of water. If you see the fund flow, this is a 50-50 scheme. We give 50% money, state government gives minimum 50% money, except the northeastern states where we give 90%, they give 10%. The fund flow was around 11,000 crores 6 years back. After the devolution of fund to the Panchayat Raj institutions, more money has gone to the panchayats. After all, this is a state subject. Water is not a central subject. As for the 7th schedule, this is a state subject. And state government is primarily responsible. Only our ministry or the central government gives technical and financial support to assist the states. From 14-15 onwards, a lot of money has gone to the panchayats. And Panchayat Raj institutions, they have the major role to play. Operation maintenance, involvement of the village water sanitation committee, the PRI institutions, everything is to be done, particularly water and sanitation services through panchayat. So money has flown more to the panchayats. Around 2 lakhs crore is going to these 2.5 lakhs panchayat of the country in the next 5 years. Every year, all the panchayats are getting 40,000 crores. So that is why, from our side, the budgetary allocation has been reduced. But we are converging with other schemes of other departments, what Sir told. We are doing convergence of water conservation measures through the NREGA, through Pradhan Mantri Krishi Sinchai Yojana, through RRR scheme of the Water Resource Department, through Rashtriya Krishi Vikas Yojana. Different schemes are there. We are converging for source sustainability, for providing water sources and all. Similarly, for maintenance, we are basically now, operation and maintenance of this scheme, we are basically focusing with the Panchayat Raj institutions. So the financially, the budget has, now it is the present year budget is around 6,000 crore. We are expected to get another 2,000 in the second stage. So let's say 8,000 crores. But it was around 11,000 crores some years back. After the devolution, it has reduced. But two major things we are doing in water, some restructuring we are doing. Earlier what we are doing, we are giving money based on some formula. Population 40% weightage, SC/ST 10% weightage, desert area, drought area 40%, like this. So based on a formula, every state we are given, you will suppose Bihar, you will be given 400 crores. Uttar Pradesh, you will be given 500 crores. You add more money from your state kitty that we are advising. As a result of this, the states are just, they are relaxing. Hamara paisa to aayega hi hamare paas. The money will come to us. So let us comfortably spend this money. So that we are changing in the restructured program, which is just going to the cabinet. On 8th of November, it will be passed. The original guideline was this, 120 pages. This will be reduced to 60 pages, but only the changes we are making, I will just highlight. The changes we are making focus on water quality, more focus and more funding for the water quality area. Number 2, the release of fund is not based on formula fine. First installment will be based on formula. The second money will be competitive based. The state which will first invest from their kitty and spend the central share as well state share, they will be reimbursed. So this will be reimbursement mode funding. Then second thing, we'll see the functionality of the schemes. We are doing third party independent surveys, and very recent surveys has seen, we have found out around 81% of the schemes are functional. When we are seeing the pipe water supply scheme, only 81% is functional. So, based on the functionality of the water supply system, funds will be released. So, 3-4 major changes we are making. It will be result oriented, competitive based, challenge mode, and output oriented, and functionality. Functionality will be a key factor, because if the schemes are not functional, the state will not be provided the second installment of money. So some drastic reform measures we are taking under the NRDWP program. So this, once this is done, we hope the states will definitely give more focus on the sustainability and functionality of the scheme. What are the major challenges, constraints? We have water resources related, inconsistent in erratic rainfall, competing use of water, geogenic contamination I have already told you, Then non-competitive formula-based allocation, the present guideline, which we are changing. Not based on sustainability of the schemes, we are just releasing money based on a formula, so that we are changing. So these are few changes we are making in the guideline. And the state from the sir told what the states are doing. Yes, if I am giving around 6,000 crores, last year the states have put in around 10,000 crores from their side. So roughly 16,000, so states are investing more money in this sector compared to some states. Because this is a state subject, so they have now realized and they are giving more money. Plus more money is coming through convergence. So roughly 16,000 crores we have invested last year. This year also many states have taken the external financing from World Bank, from JICA, from the ADB, from different lending institutions, external as well as internal borrowings from HUDCO, the Andhra Pradesh and Telangana government has taken for their Mission Bhagiratha program. So different states are taking different measures, either through their state budget or through external financing or through this plan budget or some other things. They are giving more money to this sector. Another good thing, particularly I belong to eastern part of India, Odisha. In Odisha, Jharkhand, West Bengal, mining area, lot of money is going through this district mining fund. So I am happy to say that many states are investing fund from the district mining fund. For example, Odisha itself, I am giving only 110 crores to Odisha under the formula. But Odisha is investing 750 crores. I am giving only 80 crores to Jharkhand as per the formula from Delhi. But Jharkhand is investing around 750 crores from the district mineral fund. So these are the convergence we are making, because ultimately we have to provide pipe water supply, safe water to everybody. So this is so far this drinking water side is concerned. Coming to sanitation side, in sanitation the program has been launched by Honorable Prime Minister of India on 2nd October 2014. Swachh Bharat mission we have to achieve by 2nd October 2019, 150th birth anniversary of our father of the nation, Mahatma Gandhi ji. So the objective is to provide individual household toilets as well as community toilets. When we started this program, the total coverage of India individual household toilets is only 39%. As on date, because it is a real-time monitoring, today's morning figure is 70.4%. So it has jumped from 39 to 70 in the last 3 years, and we are expected to touch 100%, the target given by the Government of India, by 2019 October. Out of 600 odd districts in the country, so far 230 districts are open defecation free, 230. Out of 6 lakh villages, around 2.5 lakh villages are open defecation free. Open defecation free means every household has a toilet. Uses, if you see, uses may be different. Toilet is there, the female member is using, maybe the male member is going outside. So we had conducted a recent survey through Quality Council of India, and they have found out around 91% uses of toilets. Whatever has been constructed between 14 and 17 and previously, okay, 70% toilets have been constructed as reported by the states. Only 91% are being used. Still it is a good figure, because in many places toilets have been built and it is not being used. So this is a major worry. The second component of Swachh Bharat mission is the solid liquid waste management. In the 2.5 lakh villages where the ODF declaration is already over, the ODF status has already been achieved, there we are telling the people to go for the solid liquid waste management. But it has not taken off in many parts. It is just started. Some parts of Tamil Nadu, in patches it has started. And we are there also, we are converging with NREGA. NREGA, we are giving the manpower, and we are giving some support from the Swachh Bharat Mission Fund. The total budgetary allocation under this program is 14,000 crores. We are expected to get another 4,000-5,000 crores in the supplementary. So 20,000 crores every year will be spent this year, next year, and again next year. So by 2019 October, we are expecting to provide India household toilets across the country in 18 crore rural household. The focus, the main strategy under the Swachh Bharat mission I want to highlight, then I will conclude, is focus on the behavioral change. Construction is not the focus. This is just an incentive. We are giving 12,000 rupees. 12,000 rupees toilet may be constructed or may not be constructed, but 12,000 rupees is not considered as the cost of the toilet. It is considered as the incentive for the construction of toilets. So behavioral change, community participation is the key. Then flexibility to the states. states have been given flexibility. Whatever material you want to use, whatever design you want to use, you can use. But twin pit structure is the direction. Twin pit toilets are our focus. Then mainstreaming sanitation in overall development agenda, focus on capacity building, close coordination with the states. Then we are also focusing, SAR is handling Anganwadi centers, focusing on the empowerment of the Anganwadi workers and ASHA workers, both for water supply as well as sanitation. Provide potable water in the Anganwadi center and toilet facility. So a lot of convergence also is being taken up. On Narega also we are doing almost 1 crore toilet every year. And the eligible people under household toilet, this 12,000 incentive is SC, ST, small and marginal farmers, landless laborers, physically handicapped and widow-headed households. And all the BPLs, BPL list mein jo bhi hai, sab all are. So this is basically the focus on Swachh Bharat mission. It is basically a massive program, biggest program, and so far we are on right track, and we are quite hopeful by 2019 October we will achieve the target fixed by Government of India. Thank you.
Now, may I request Mr. Raj Gopal to tell us what is the Interstate Council Secretariat's broad concern? It's an entity that not everyone is familiar with, so I think, sir, if you could introduce that body to the crowd, it would be useful. And then tell us what is the current involvement with health and or potential future involvement.
Good morning, ladies and gentlemen. I think the subject of discussion today is about how we can improve healthcare through fiscal federalism. And the Interstate Council and the zonal councils, which actually represent a kind of a coordination mechanism within the Constitution of India, to involve the states and the center together in a national effort, play an important role in this. The points which I would cover in my presentation would be something about what the Interstate Council has been doing and what the zonal councils have been doing. What happened in terms of transfers between the center and the states, and what's happening at present. And what's the perception of the states, because in a way there's nobody to represent the states here, so the Interstate Council takes upon itself the responsibility to provide some views about the states as well. See, the Interstate Council is a body under the Constitution of India. It's been created through a presidential order. It's been in existence for the last 25, 26 years. The purpose is basically to bring about better coordination between the center and the states. Now, so the Interstate Council can adopt whatever measures it wants to make sure that coordination efforts between the center and the states improve. It's headed by the Honorable Prime Minister, and it has the union ministers, 6 of the important union ministers as members, and all the chief ministers are members of the council. Besides that, you also have all the other important ministers of the cabinet at the center being invited to the council meeting as special invitees. So it's actually quite a well represented, quite a powerful body, and it can move mountains, in case you want to use the word. There is also a provision for, we also have the zonal councils. The zonal councils are regional bodies where we have the Home Minister chairing meetings with the chief ministers of those regions representing their states at the zonal council meetings, and we have 5 such zones in the country. These pertain to different parts of the country, as you can make out: north, south, east, west, center. And what's discussed in the zonal council meetings can come over to the Interstate Council in case it has national ramifications. Now, basically, there are a number of issues with regard to fiscal transfers as far as the center and the states are concerned. And one of them, of course, revolves around the point about whether there is adequate funding taking place. Now, I think speakers at various sessions yesterday might have talked about 32 to 42%, so I'm not going to go on that point further. But basically, the issue is the states are much better endowed with funds today than they were probably 5 years back. So the states have really no reason to complain if one looks at it in terms of absolute transfer of funds. What does the state do with the funds? Now that's another question which has to be answered, because it's not merely the amount of money being transferred, it's also how you deploy that money that's important. Health is a state subject, and that's already been mentioned. I don't want to labor on that point further. But basically, every state has its own way of looking at health issues. I think it's got a historical background to it. Certain states attach more importance to health, certain states attach less importance to health. Certain states feel that health is a very important concern when it comes to fighting elections, and certain states probably feel health is not so important when it comes to fighting elections. So it's again a question of how the electorate views health as an issue. And I think that also decides as to how much of importance the state provides for health care. The center, of course, as Secretary WCD already mentioned, has a very important role to play in terms of nutrition, in terms of correcting up various factors at the basic levels. But the state is the one which actually delivers the service. So the efficiency of delivery is another very important point. It's not just the fact that well, does the state attach a lot of importance? Maybe yes, the state attaches a lot of importance, provides a lot of funding. If you look at the National Health Mission, 40%, maybe some states do provide the funding, but do they attach importance to the efficiency of public service delivery? Now that's again something which needs to be looked at. The monitoring is very important. The fourth item which I would probably stress upon is the fact, do they have adequate personnel to monitor and to carry out the activity? Now you might want to have well-equipped primary health centers, but do you have enough doctors? Do you have enough nurses? Do you have enough nurses going to all parts of the state? Enough doctors going to all parts of the state? Just to give a comparative example, I mean, I know these are not examples to be looked at in terms of which state has done well, which state has done badly. That's not the point at all. But I'm just saying, let's look at one state probably which has more doctors than are required at the PHCs. Now, one of the southern states, for example. Now, there is another state probably which has less doctors than are required at the PHCs. Now, how do you compare performance of these states? It's impossible. Even if you have the funding, you have all the equipment, you have the buildings in place, you still need to have the personnel. So I think these are a number of issues which the states have to address. It takes time. Now, the efficacy of a program takes time to be actually perceived, to be actually felt at the ground level. And more so in terms of figures, if you're a researcher, maybe when it comes into actual research work, it takes probably 20 years or 15 years for that to be reflected in a research publication. But I can tell you from my experience, the director Saab has just told me, I mean, I should also talk about my state. And so let me tell you that one of the important factors that resulted in better health care in Tamil Nadu, the state which I come from, was the noon meal scheme, which was started way back in 81 or 82. And at the time the scheme was started, everybody dismissed the scheme as something which has no relevance. And we used to have a very clear distinction between plan and non-plan expenditure those days, and the Planning Commission simply said, no, it can't qualify under plan expenditure. I was in the finance department those days. We used to be struggling very hard to see that the plan expenditure at least, was boosted by the fact you had the noon meal outlay in that. But today, the distinction between plan and non-plan expenditure has also been eliminated. So it actually, it makes it easier for a state to spend money on such schemes. But for that scheme to be actually felt in the sense at the ground level, it took about 10 years. Because, you see, the point is the nutrition levels improve automatically. The dropout levels in schools go down automatically. You find families attaching a lot of importance to children automatically, because they say, well, what's the point in having 4 or 5 children if we are absolutely certain that these children which we have, maybe 1 or 2, are going to be well looked after. So it is this kind of confidence building. I would call it a CBM. It's a confidence building measure. It takes time to actually percolate. So once it percolates, you would actually have the result, and that result would be in the long term. So we are all, I think everything is going well. If you look at the 13th Finance Commission, there was a kind of a special grant attached to lowering IMR. If you have the 14th Finance Commission, you have had an increase in transfers to states, a very substantial increase. The finance minister was mentioning at the last interstate council meeting, the first year saw a jump of about 1,80,000 crores in terms of transfers to states, I mean, which is absolutely unheard of in India. So it's a question of how the states are going to utilize the money. I think that's where it is important. As far as healthcare at the low levels is concerned, I think another very important point which I'd just like to mention is I think the importance of rural roads. You might have PHCs, but if they're not accessible, you might have primary health centers or community health centers. So access is also very important. The special importance which Government of India is now paying to proper rural roads being in place, connecting up habitations, as my friend was mentioning, 17 lakh habitations being connected up to main roads, roads which are motorable, which lead to PHCs and to CHCs. I think those are going to play a very important role in improving healthcare. Thank you.
So I have one question for each of you, and then we'll open it to the general audience. For nutrition is, I presume, the strongest connect of the WCD ministry to the broader health. In fact, most of us in research also, it's health and nutrition. It really is a combined effort. So what are the current mechanisms through which, for instance, when you give us a sense of measurements, it is NFHS. NFHS, the last one was held 10 years back. What is that monitoring or that mechanism of constant surveillance used, so data systems, which the WCD is using to monitor the nutrition program of the government of India?
You are correct. Actually, the NFHS data is available to us once in about a gap of 10 years. And we find that it is not adequate for us to plan any public policy. So what we have done is that with the help of the World Bank, we have started the ICT RTM and the CAS, the Common Application Software. This is being given to about 1,76,000 Anganwadis. These are located in 8 states. We have started with 8 states to begin with, and we are giving smartphones to all the Anganwadi workers, and then we are giving tablets to the supervisors. You are aware that over a group of 25 Anganwadi workers, there is one supervisor, and then over about 3 or 4 supervisors is a CDPO, and then you have the district project officer, and then you have, of course, the state level directorate. So what we are going to do with this ICT CAS is that in the smartphone, we will be able to capture, because we are linking the beneficiary to the Aadhaar, and we will be able to capture, because the real problem lies, the leakage also we have been able to detect, it lies in the administration of take-home ration, which is given to pregnant and lactating women and to slightly younger children, because older children can have hot cooked meal which is served in the mornings. Usme there is not much of a leakage, but the main leakage, and leakage to the extent of 75%, has been detected in the take-home ration. So in the take-home rations will be barcoded, and in the smartphone we will be able to capture the image of that barcoded package of take-home ration that is being given. We will be able to know exactly which packet has been given to which beneficiary. That is one aspect. The second aspect is, with the help of this smartphone, the Anganwadi worker will be able to know which child has not been coming to Anganwadi for, let us say, past 10 days, past 1 week or so, which child is showing a decrease in growth, which child is showing loss of weight, all these things. And then in case a child is detected with a low body weight compared to his age, then immediately an alert is sent to his parents, because now almost 90-95% people of this country, they have the mobile phones. So alert goes to that child's parents, and a copy of that goes to the sector, to the supervisor, and also to the CDPO, and also to the collectorate. So that is the type of real-time monitoring that we intend to do. I may add that what we have found is that mere convergence among ministries is not good enough. If we have good convergence with health and with the drinking water and sanitation, that alone by itself is not good enough to tackle this menace of malnutrition. Actually, this also is a state subject, as my friends have already said, and it has to be implemented at the state level. Therefore, with the help of the Prime Minister's office, we have issued instructions that collectors have to meet once in 3 months only for reviewing malnutrition, to the exclusion of all other items of monitoring. Because generally collectors meet and the meetings are basically devoted to the revenue aspects, the law and order aspects, the visit of some VIP, and nutrition is given the last priority, and by the time the nutrition is reached, the collector has already lost his patience. So we have said that at least once in 3 months you will monitor this level of malnutrition, stunting, wasting and all, and see that it is progressively brought down. We have addressed a letter to Niti Aayog to give us a dashboard of what factors and how to monitor, because we have been, after we have carried out, as per the Prime Minister's orders, he said that you concentrate on the 100 most backward districts. So we have identified 113 most backward districts from the point of view of stunting and wasting and all, malnutrition, and we have called their collectors along with the principal secretaries of health and nutrition and principal secretaries of WCD. We have told the collectors that we will now be monitoring. You please hold a meeting every 3 months and you send us the reports, so that we will also come to know which collector is doing his job seriously and is taking this seriously. Once this work gets underway, this has started only in June this year, once it gets on ground, then I think that to a very, very large extent we will have real-time data. We will no longer be dependent upon the NFHS data. You will have data at your fingertips on an hourly basis, and you will be able to know exactly what is the level of malnutrition and stunting and wasting in which district. And not only that, you will also come to know that after an alert that had been generated by the Anganwadi worker, what efforts have been made by the higher authorities. Supposing the parents of the child are still not bringing him to the Anganwadi center, then whether the supervisor has gone and paid them a visit, or whether the CDPO has paid them a visit, and if not, they will be asked questions, why you have not done this. So this is the type of real-time monitoring that we intend. This has already been done. We have already state-wise, Director Saab was saying, so the states are basically, MP is there, UP is there, Maharashtra is there, and I think Andhra Pradesh is there. There are total 8 states, but it is regrettable to point out that UP and Maharashtra have steadfastly refused to implement this scheme. They have not been able to place their orders for the smartphones, which as per Prime Minister's orders have to be placed on GEM. Other states have followed suit. It is not that we are not doing anything about it. We are talking to the chief secretaries and we are trying to bring them also on board, because we want to start this on a real-time basis in all these 8 states. Once we have achieved success in the 8 states, which we are bound to achieve because this is a very foolproof type of arrangement, we are going to make it pan-India. And we hope that by this method, we will be able to have the real-time monitoring of nutritional aspects in the country.
Thank you. So we'll get to questions in a minute. Now, the one response to that is that, you know, the HMIS database that the Ministry of Health is putting together, in fact, there is a great effort through Niti Aayog where we are trying to track districts based on some of these data sets. Now, the issue is the quality of the data, sir, is only going to be, we are only going to be able to tell what that quality is if it is used. Now, that usage to a large extent should be made easy. For instance, putting up PDFs of data really doesn't do much. So I think maybe either linking the HMIS of the Ministry of Health along with the WCD, the kind of data you're picking up, at least the district level, and making it open for social audit is really moving towards democratizing health and nutrition, at least from a data standpoint. And we do have a lesson from Brazil. In fact, one of the, the fanciest idea that we can now experiment with is the kind of data systems Brazil has put in place for healthcare, which is in different verticals, but they're publicly available and they have been integrated. So I think that is one thing to look at. My second question is to you, sir. Is there any kind of social audit or monitoring happening as far as the water, availability is concerned. That's number one. And number two, we are saying that sanitation, toilets, open defecation free aspirations cannot be about construction. So there is a great degree of, convergence on that belief. But as far as usage is concerned, what are those behavioral changes that the ministry is looking, at promoting? And I know that your focus is rural, but it would be extremely helpful to this crowd if you could very quickly give us a sense of also the push for water and sanitation in urban parts of the country.
Urban area, it is difficult for me to hear because they are also doing through their Amrut scheme, Atal Mission for Rejuvenation of Cities. So a lot of fund has gone to the cities they are doing. So, but rural scenario, yes, I can tell. Social audit is part of our guideline. It's very clearly written. What WCD Secretary Sir has told, it is a state subject and we have different institutions at different level. Right at the GP level, we have the Village Water Sanitation Committee. Okay, the Village Water Sanitation Committee, they flow information. There is a JE at the, for every 3-4 panchayats, there is a junior engineer of the Department of Rural Water Supply of the State Department. So the information flow or whether it is working, not working, water supply has stopped, all these things generally, as per the guideline and instructions from the center as well as state government, it should come to the, or the quality of water come to the local junior engineer. Then it brings to the block level assistant engineer. There is an assistant executive engineer at the block level. Then there is a district water sanitation committee under the chairmanship of the collector. Of course, collector is busy. He is chairing almost 150 meetings every month, what are told, hardly he has time. So, but this is a focus in many states. Regular collectors conference we are also holding. Some collectors are called champion collectors. They are mixed with other collectors to motivate them. So the district water sanitation committee, they also do some kind of checking and monitoring. It is supposed to, they are supposed to hold monthly review meeting along with health and other things. When we were in the district, 20 years back, we were doing that. Every month, 5th of the month, we are doing that. So now I don't know what the collectors are doing, but this is the mandate of the guideline as well as the ministry as state government instructions. You do regular checking and through the village water sanitation committee and the PRIs. Then coming to the ministry side checking, yes, we send the national level monitors. We have around 10 to 12 national level monitors. Every monitor has been given 2 to 3 states. So they do visit in each quarter, every state. They randomly check without informing the state officials. They go and check it, then give their feedback to the state secretary as well as the ministry. So then only we do the repairing or damage control things from Delhi level or from the state capital level. Then we have also started, as per the new guideline which is being restructured, on annual basis we will have a third party evaluation. But last year we did it through Niti Aayog. Few schemes were checked randomly, ma'am, around 50 schemes in 6-7 states. And around 5,000 village water supply schemes were checked by the Quality Council of India. So there I told you 81% functionality we could found. And it is a detailed checking whether water is available in school, in Anganwadi, whether it is coming 2 hours in a day or 6 hours in a day or 1 hour in a day. So it all checked from Delhi through a third party agency. It continued in December, January last year and in around 6,000 villages. So this is the level of monitoring first right at the beginning from village level, then district level, a block level, then district level, then state level. Of course, there is state water sanitation mission. In many states, the Honorable CN, Chief Minister, he chairs the meeting. In other states, the minister, in somewhere it is secretary. So this is the monitoring and social audit. Yes, social audit is part of the guideline, but in some states that do, social audit mein Chopal mein gaon mein baithenge in some central place and they will discuss about this issue. And mostly the sanitation things are decided at the Chopal level or the village level, village Chopal, they are telling. And regarding this behavioral change in sanitation side, lot of software activities are going on. In fact, our 9,000 crore sanitation, World Bank supported sanitation project is also going on, ma'am. This has just started. And their incentives is given if community build their toilets. For example, I'll give an example of Chhattisgarh state. Chhattisgarh, in a village, 80% people had toilet and 20% do not have toilets. So 20% were found to be not eligible as per our guideline. Okay, either they are APL or they have taken toilet in 1985 because toilet scheme in some form or other has started way back in 1986, 87. then Total Sanitation Campaign, then Nirmal Bharat Abhijan, now it is Swachh Bharat Mission. So in different names it has started way back in 1986. So some people have got toilets of 400 rupees, 600 rupees, 2000 rupees. Gradually the amount has increased incentive. So they are now no more eligible because already they have got some kind of incentive as per the government system. Otherwise audit will catch. So these people were not able to get. So some eligible people, suppose there are 20 eligible people and another 10 ineligible people in a village. The 20 eligible people, they pooled all their money, 12,000 into 20, 2,40,000, and they collected some building materials, they gave some shramdan, took some labor wages from the Narega, and they constructed 32 toilets. So this is the model. So this is the behavioral sense. Everybody is set together. 20 are eligible, 12 are not eligible. So 32 ke liye ye 2,40,000 hamare jo paisa ko they spend the money. So this is basically meetings, interpersonal communication, the house to house visit, door to door visit. So these are the way we are doing, and exposure to good areas. In the same district, some villages are doing well. So the villages which are not doing well, they are being taken to the other villages, stay there for 1 or 2 days, interact with the people, and basically we have taken the ladies group, women self-help group, the youth club leaders, the local champions as the motivators.
May I recommend a Garv-like portal for what you're doing, as the Ministry of Power has done? It will be, and maybe the researchers in the room,
SPM, there is a beautiful, there is a portal and...
yes, I think it would be great if
it
we
is a real-time monitoring. In fact, they are very active. I'm looking at the water side, but they are very active in the social media also.
Wonderful.
If you see Facebook and other things, this Swachh Bharat, all success stories, all good things are being highlighted.
Very nice. My third question is to Mr. Rajagopal. You know, the mandate, one of the founding mandates of the Niti Aayog is competitive or cooperative federalism. However, it is one organization, obviously doing many things limited in capacity. It is an obvious partner to the interstate council. So can we use, this is a very pointed question, can we use your secretariat, sir, for sharing best practices across states as far as health and nutrition is concerned?
I think it goes without saying. I think we have to work in tandem with the Niti Aayog because that's where you'll be able to get across to the states without a communication gap. And yes, I think we have been telling states to share the best practices that they have amongst themselves, and we provided a platform in the Secretariat. I'm sure the Niti Aayog also has a similar practice going on. So either of them can be used for spreading best practices, which is actually not a problem. I mean, today I think people are willing to learn. We had, I mean, just to give you a mention, just to mention about the land pooling exercise in Andhra Pradesh. Now, I think that was a fantastic effort where land was acquired for the national capital without paying a penny. I mean, all the land that was required for the national capital, the newly created state, was acquired without paying a paisa. So that was a practice which we did transmit it across the states. We had a meeting. I mean, so this can be done. So that's the short answer to the question. Yeah.
Thank you. So now we open it to the floor. We start with you, Avni. It would be great if you identified yourself in a line, please.
And use the mic, please.
Yes.
Look at the vote of thanks. Yes, I'd love to give some closing remarks. One, of course, that I think it has been a fascinating 1.5 days. Today I've been more out than in because tomorrow we have a VVIP, Vice President coming in. So lots of, last minute changes happening. But I think a lot of us have had tensions with the fact that state and the union. And which is why, in fact, the origin of the conference goes back to that only. The fact that legally and now fiscally, we are coming on alignment. Any such change, it's a transformational change, any such change is necessarily disruptive. Now, there are short-term costs to be borne, but we can't be looking at long-term remedy to short-term in sense, So, should the central government, the government of India, the union government be doing it just because there's a problem there? yes, humanitarian-wise, you must do something. What is the something, So let's all do something about the pollution of Delhi. So somebody shuts down cars for one day, somebody shuts down patakas. Trying to do something is not always the right option, Trying to do the right thing is far more important. And I think, and that's why I was very keen, and I'm glad the Interstate Council is with us, the Niti Aayog was here, is that bodies in the government who have the convening power, one, and bodies in the government who have time to think. Now, ministries do have their limitations, and I'm not running down anybody in the ministry. It's a tough job being in Government of India because you're responsive immediately. You have to be reacting very, very quickly all the time. You don't have the luxury of time on your side. But bodies in the government like the Niti Aayog who have mandate job is to think and work with states and bring the experience together, and the Interstate Council convening powers. I think just the understanding on how you can make this transition, get better outcomes. But the answers are not always easy, and I'll just read you some statistics. I'm familiar with a territory called the Andaman and Nicobar Islands. Its health outcomes are simply outstanding by whatever norm you take. The per capita income is high. Centrally funded territory, so you have lots of money, but money is not a solution because when you're separated far from each other, my biggest problem used to be not enough doctors, We have the X-ray machines, we don't have the technicians available, Simple thing that really causes. But it has excellent health outcomes. Households with electricity, 99% urban, 95% rural. Drinking water, 100% urban, 96% rural. Girls with education, women with 10 years or more of schooling, 42% rural, 57% urban. So every which way you go, TFR 1.4. So every which way you see, high per capita income, etc., is excellent. When you come to nutritional status, institutional births, 98%. Institutional births in public facility, 92%. C-section, which has now become this thing, low in the rural areas, 12%, 24% in the urban areas. And C-section, as you know, has become now a choice. It's not a medical necessity in most cases. The polio vaccination, everything is outstanding. Child feeding. Nutritional status, when you come to children between the ages of 6 months to 59 months who are anemic, 50% rural, 47.7% urban. So while on every other count you're scoring very high, suddenly you come up with this. Pregnant women who are anemic, 65%. Staggering figures. So on one hand we have seen the public system, and Andaman is purely public. In the town of Port Blair, there are about 5 private doctors. Everything is purely public. Every which way you have delivered, and yet, suddenly when you come to nutritional status anemia, you find this. So obviously, of course we've done many things right, but the obvious answers are not present. It's a predominantly non-vegetarian, so people eat a lot of fish. People eat a lot of non-vegetarian food. So you should not have these figures, right? So where do you think we made the mistakes? I don't have the answer to it. I'm merely raising the point that there are lots of problems to be sorted out, and the best part is to therefore work together and learn from each other. The work, Shamika, that you do, or Santosh, you do, or others do. I think all that has to feed into the policy cycle, learning from Brazil, Polsha, Escola, and unconditional cash transfers, Canada, etc. I think there is a need to learn from everybody, all the above. I don't use the word best practice. It's a pretty bad word. I don't particularly like the word best practice. I don't even know what it means actually. Other than giving some of us some jobs occasionally, as consultants really does. But but sheer learning from each other suddenly will help you bridge the gap. And therefore, doing something is not always the right option. Doing it right is possibly more difficult. But which is why an exercise like this, and I hope we can build on it, is something much more. Interstate Council. Because we need people in the government to be meeting researchers and scholars and practitioners more often at different levels to be, this osmosis process is so important. It is our small effort to do that. Let me not stand between you and lunch, which I can smell. Professor Rekha Saxena, who's professor of political science, works on federalism for a long time. They have this Center for Multi-Level Federalism, associated with the Forum of Federations. So I would request ma'am to have the last word.
That you have given to me, because as an academician and I teach at Department of Political Science, University of Delhi, and I've been working, I'm not an expert on health policy or fiscal federalism, but I work on political institutions. I've been working on federalism for the last 2 decades, and I've written extensively on these areas. So I cannot refrain from making few observations before I give vote of thanks on the basis of last 1.5 days of discussion. I think there are 2 recent developments that have greatly impacted the healthcare policy in India. First is the neoliberal economic reform since the 1990s that brought the new ideology of promoting the market forces and entailing the departure from the Keynesian perspective, that had argued for active role of the state in stabilizing the economy and promoting public welfare. Now, thus the state, the aggregate state has, tended to wash its hands of its important role in social sector areas. As a result, I think the healthcare in India, that has become quite expensive, especially even for the middle class, it has become non-affordable. Then the second development that has impacted this policy area is the 14 Finance Commission report, that gave, states a shift from the increase of 10% from the divisional pool from 32% to 42%. So in its trail, I think the government of India has been folding up the centrally sponsored schemes practically in all areas, especially in healthcare. And on the other hand, I think the state governments, they have also not put together their acts in devising their own healthcare policies. So there's a kind of vacuum in this transition from one regime of health policy to another. And I was doing a project with funded by Liverhome Trust in UK, and it was on continuity and change in Indian federalism. It was a 3-year project, and we did case studies of ICDS scheme and Anganwadi centers. And we did a study in Gujarat and Orissa. So, but there's no time, but we are publishing, papers based on those studies, and a paper on transition from Planning Commission to Niti Aayog, it has already been published in a foreign journal. Now, so my point is, what is the way forward now? One obvious step would be to faithfully implement the objectives which have been outlined, I think, in the National Health Policy of 2017, that aims to increase health care expenditure to 5% of the GDP from present rather low level. The target of this policy is also to increase the central government's expenditure in health from present 1.4% of GDP to 2.5%. Now, this is urgently required as India compares very poorly in regard to not only the developed Western democracies, but also progressive East Asian economies and democracies like Japan and South Korea. And then another desirable step to improve the situation in this policy sector could be to create a consensus for transfer of health from state list to concurrent list in the constitution, whereby I think both the orders of governments could acquire competency as well as responsibility in healthcare jurisdiction. Further, I think there's also need to activate the Constitutional Intergovernmental Agency of Interstate Council. This point was also made by Ravi Dhingra ji yesterday, and which represents both union and state governments to formulate, harmonize, and monitor healthcare policies at all levels. And I wrote a piece on in fact, my PhD was on Interstate Council, and one of my book is on Interstate Council and National Development Council. And I interviewed some bureaucrats that time when I was writing another piece on intergovernmental relations, and I interviewed Mr. A.R. Nanda, he was the health secretary. So he mentioned that the reality of intergovernmental relations in India is at one level below, that is at the level of bureaucrats or deputy ministers or secretaries. So he was mentioning that health ministers, secretaries, they meet almost biannually to discuss, policy coordination and other issues. And then furthermore, I think there's need to change the strategy of top-down, like Shamika, you mentioned in the inaugural session, to change the strategy from top-down policy-making implementation in this area in favor of bottoms-up approach with public participation at all levels involving NGOs and civil society. Besides, this point was also made by Govinda Rao that the regulatory regime in the healthcare sector that has been shown in poor light in recent years, especially the Medical Council of India. There was suggestion by Niti Aayog to disband it, but it has not been implemented. So such regulatory mechanisms are important, but I think there's need to have some kind of more foolproof mechanism of regulation which has not been implemented so far. And so finally, on behalf of Forum of Federations, I would like to thank all our esteemed panelists for making very insightful and analytical presentations over the last 1.5 days, and especially to our foreign delegates who took the pains to come all the way for this event. And thanks are also due to our host, Shakti Sinha ji, Director of Nehru Memorial Library, and the entire staff of the library, and our co-sponsors, Brookings India, Shamika, and Interstate Council Secretariat for putting together such an amazing conference. And I would like to thank other esteemed participants for their very important interventions. And also, thanks are also due to our country director, Ravi Dhingra ji, for his guidance, and also Vikas for his support. Thank you so much.